Appreciate the opportunity to both hear Nikki's presentation again. I love the work that she's doing, and to spread the information and the impact of what we've been able to accomplish here at Region 4. Count it a privilege to do that. So next slide, please. We'll be talking about our Community of Care project, which really is about transformational work around the complex care needs of older adults, and embedding social care clinicians into medical teams, and really working toward not just handoffs and handshakes, but really working arm in arm with our medical care partners in the community. Next slide. So if you think about who AAA is, who this AAA, who we are in the southwest corner of Michigan. We have a tri-county planning and service area. It is a mix of high poverty and mass wealth, very diverse populations, rural, urban. So it's a bit of a cross section in terms of the population that we serve. Next slide. So why this matters, this partnership is focused in one of our counties, so in Berrien County. And as we think about the aging of America, our Michigan is aging faster than the rest of the nation. In fact, 51% of older adults in all of America live in 9 states. Michigan is one of those states. So we are aging faster than the rest of the country. And in fact, Berrien County is aging faster even than the rest of Michigan. So we look at the percentage of older adults with chronic conditions and the number of older adults who have nursing home level of care needs, who have low income. So really a data-driven approach to identifying our target audience and what the issues are. Next slide. And when I talk about what are the issues, what problems are we trying to solve, we want to look at this not just from the AAA lens or from the community-based organization lens, but from our partner lens too. So our work goes back to developing a shared purpose. The Healthy Berrien Consortium is a group of the CEOs and thought leaders from all the health organizations in our community, inclusive of the health system, public health, behavioral health, and the Area Agency on Aging, and really looking at what are the needs in our community and then developing collective solutions to meet that need. And so we identified a community need, again, collectively. And I think this is, you'll hear this theme from us. It's about not just what we bring to the table, but what do we bring to the table to solve a community need felt by all of our partners. So we identified, actually this was pre-2010, I think it was about 2009 that we began this work just collectively, understanding that older adults who have multiple chronic conditions, they were experiencing some of the worst health outcomes in the region, often resulting in disability and avoidable death. Next slide. So as we came together with that, we developed value expectations for our partnership. What is it we want to achieve with this? So the primary value expectations are that we would achieve stabilized health for seniors with multiple chronic conditions. Important to this work is increased caregiver and social support. Can't get to the stabilized health without making sure that we engage caregivers and we provide social support. You'll recognize this language perhaps from the healthcare side of our partnerships, reducing the cost of care overall by driving the right care at the right setting at the right time. And underpinning all of this, we were determined not to just go after grants and do this work with a proof of concept. All of that is important, but get to a sustainable payment model and capacity building to make sure that we can continue this work long term. Next slide. So as we worked through that, we developed a pilot project to do that proof of concept. We developed the interagency care team pilot project that did indeed demonstrate the impact of integrating medical and social care. So embedding our social care clinicians with medical care teams to get into the home and identify the health-related social needs, although we didn't even have that term in 2010, and tap the network of community-based organizations to meet those needs. And we saw, as you look at those trend lines, just a significant reduction in medical care cost and improved health outcomes. And that pilot project, through that work, we identified billable Medicare codes for chronic and transitional care management to sustain this work going forward. That's the foundational, and that moves us into what did we do from that proof of concept, that pilot work, to evolve into some contracts. And I'm going to tap Theresa, the Chief Operating Officer, here to begin to talk about that transition into that evolution of community of care. Next slide.
Thanks. As Christine mentioned, we engaged in this work with our healthcare partners. So that team of leadership from the Healthy Bearing Consortium actually became true champions of this work. They experienced throughout all phases of the pilot, they saw and experienced this proof of concept firsthand. They experienced reduction in their provider stress and frustration in not being able to impact social care needs. They knew that were underlying and influencing their ability to impact medical outcomes. They saw the better health and stabilization of their patients and improved patient engagement and satisfaction scores increase and go up, ultimately resulting in that line that drives down lower utilization and cost. We worked with those champions to execute contracts with these two primary care practices that are referenced on the slide here to integrate and embed the AAA social care clinicians into the medical care team. Of note, those two practices, one of them is a home-based primary care first model. The other is an office-based rural health clinic. It really demonstrates that there's success in this model of integrating care, and it can work in a wide variety. It can be replicated in a wide variety of reimbursement models. Being embedded in the medical care team then means that there's no longer siloed care. The medical team really introduces the model to the patient and caregiver as seamless. They're not just referring to the Area Agency on Aging and saying to the patient, we're going to refer you to Area Agency on Aging. It's really my colleague, Theresa, is going to give you a call and talk to you about what's most important to you as we all work together to help you make you feel healthier. This model extends, as I said, beyond warm handoffs into these huddles in person every week. During those huddles, new patients and emerging needs of existing patients are reviewed, and we care conference together. And each clinician, the social care clinician and the medical care clinician's perspective, knowledge, and ideas are respected and included. In between those huddles, then, they often call and message with one another to address urgent needs, just as one would a colleague in their fellow practice. I glossed over the shared care plan there, but it's really one of the most important and invaluable pieces of this model. The AAA social care clinicians document their encounters in the medical record and contribute their findings and interventions to a single comprehensive care plan. As an Area Agency on Aging, then, we also bring, just as our sister AAAs do, we've long acted as community care hubs, and we bring under our area plans for the Older Americans Act contracts with CBOs to plan where we're developing a coordinated system of services to meet these social and health needs of older adults and caregivers. So for us, that's 100 plus partners and providers, as Nikki mentioned, of all different shapes and sizes, providing a full range of different services in the community, from nursing in the home delivered meals, PERS, assistive technology, transportation, the whole gamut of health-related interventions. And that's really the value proposition that Area Agencies on Aging can bring to the table to potential care, integrated care contracts that already exist within our network. Next slide. So this is a really high level overview of the integrated care workflow. As you look at this diagram, please be thinking about what components of this work you're already doing. I think you'll find that you're probably doing every element of this work already, just to greater or lesser degrees and in partnership with one another as health systems and community-based organizations. As I mentioned, our teams meet regularly each week to huddle on new and existing patients. The aligned workflow includes sharing materials and shared language. That was really key to the success of this model. Is we really are transforming the philosophy and model of care. We're ensuring that everyone, including the patients and their caregivers, are working towards the same goal and reinforcing one another's messages. It's really focused here on the patient and the caregiver. That was new for a lot of our medical teams, very highly focused on the patient before we began working so closely together. It's holistic, it's guided and collaborative rather than instructive, and it's really focused on what's important to the patient, not only what's important for them. This is a model that circles back around, and engagement leads to person-centered assessment and care planning, leads to intervention, leads back to engagement and around again. And it's really underpinned by this community of care. That's how we refer to our community care hub, all of our social community-based organizations in the community. One of the things that is not really noted specifically in this integrated workflow, but is core and important to the work that this collaborative is getting together around, is care transitions. Our social care clinicians learn right away that if a patient of ours, a shared patient, is in the hospital or ED, and can intervene immediately, helping to reduce that length of stay, but connecting them to those resources in the community and to the core services that we were already providing as an area agency on aging, like falls prevention, medication reconciliation, home safety evaluation, caregiver education and classes, evidence-based programming and health coaching, some of the things that Nikki referenced as well.
Before you move on,
Yeah.
Theresa, if I could just maybe layer on a little bit, because I realize we haven't talked about, when we talk about engagement and patient selection, we haven't talked about the population we're serving. So we're talking about older adults with multiple chronic conditions, but we're very specific. It's older adults with multiple chronic conditions who have a complexity score of 14 or greater that comes out of their medical record and are experiencing high hospitalizations and ED utilization. So that's the target population. And our team, as they're documenting inside of Epic, actually have the opportunity to help influence where that complexity score goes in terms of their social needs. So I just wanted to kind of set that context. And it's not just the hospital or the health system saying, these are the patients we'd like you to work with. It is collectively care conferencing on patients and as those are proposed. And our team also talking with the medical team to decide who should be enrolled in this project. So I just want to layer that on, because I think that's a real nuance and important factor of how integrated this team is.
Mm-hmm. Very good. So of note, prior to this, we heard from medical clinicians in these practices that they really felt alone and ill-equipped to address or meaningfully treat the issues that they saw getting in the way of their treatment plans, getting in the way of their patients making healthy changes. Simultaneously, we heard frustration from social care clinicians who are feeling like their attempts to influence the treatment plan or help primary care teams understand what was really going on and at the heart of what their patients were experiencing poor health, the daily barriers and challenges weren't being prioritized, and in some cases even devalued. This really transformed the way that the teams talked about patient care, talked about their work, and the value that they saw in each team member being at the table. Next slide. So I think this is a really impactful visual to talk about as you're having conversations with your partners or potential partners. These are some of the results that we saw from the patients that we were co-serving. While new requirements in advancing research on social determinants of health have resulted in health systems and medical providers being increasingly aware and screening for 3 social determinants of health: insecurity when it comes to food, transportation, or housing. The deeper assessment of individuals' health-related social needs really reveals many more underlying needs, most of which are only really discoverable when relationship and trust are built over time and care is extended into the home. Again, what we talk about with and what our medical partners have seen is care health really happens between those visits to their primary care provider. It happens every day with the choices and the barriers that people are confronted with in their daily life. So some of the highest needs that we saw were actually mental health needs, things like major life stressors, mild, moderate, and recurring mental health symptoms, loneliness and isolation, stress and family conflict. We saw a lot of limited informal support and caregiver strain. And when it came even to things like food insecurity, we saw that health literacy, health education, and coaching really underpinned that. It was more complicated. Just as you can see there, housing is far more complicated than somebody having a roof over their head. It comes down to the quality, the accessibility, the affordability of housing. So it's really about finding those root causes and meeting them with solutions from the social side of things that drive value and return on investment that we saw. So next slide, please.
So as we address those health-related social needs and identify and address those, we have some remarkable results. So the outcomes of this, this is pre six months data compared with post 6 months data, and this was an independent evaluation by a local university. This project showed an 86% reduction in unplanned inpatient hospital stays. We didn't include things like if someone had a knee replacement scheduled, but it's 63% reduction in ED to inpatient stays. So if our patients hit the emergency department, our social care clinicians were able to get involved and get the supports put in place so they could go home instead of into the hospital. A 100% reduction in ED to skilled nursing facility placement. So if they hit the ED, we were able to get them home and not get a skilled nursing placement for the patients. And just as importantly, and I think key to some of those success underpinning it, is 93% of caregivers indicated that they feel supported in their caregiving role. And why these indicators? These are the KPIs our health partners are. These are the markers they're trying to drive. So these are great indicators, and having these get your health partners attention when you show these kinds of results. Next slide. So what does that reduced utilization translate to in terms of dollars? So for 93 patients, we had an overall total cost of care reduction by 63%, which translates to a $1.7 million savings for just less than 100 patients. And so as we talk to our healthcare partners and potential new partners, we talk about investing. What it takes to drive this kind of saving is investing some of those savings into those social care supports to be able to get at that. It's not enough to just identify and refer to community-based organizations, but you really have to fund those social support systems. Next slide. So why this partnership works, lots of words here on this slide and you'll get it, but really it allows the partners and our providers and partners and patients to set collaborative goals to, again, as Theresa said, talk about what's important to the patient, what's important to them to work on, as opposed to what from a clinical perspective we might think it's important, allows broader perspectives and more proactive tailorized or personalized approaches to complex needs, and improves patient and caregiver satisfaction. Certainly by reducing the total patient cost of care is driven by efficient use of community-based services. So much less expensive to treat the bed bugs than have people keep hitting to the ED because they won't let skilled care come in. That's an actual example. Theresa, did you want to say a few more things about this slide?
I think that the slide speaks for itself, and I know we've got a lot to go through.
Okay, we can go to the next slide then. There's some great quotes from our partners in the field about how participants have greater access and how the way that this community of care has changed the way services and care are provided. And these two quotes are from our medical care partners. So those are really impactful. And the next slide, as we look at how do we pay for this, these are the billable codes that we're currently using. Theresa, you want to speak to this a little bit? And then I've got one or two things to say about it.
Yeah, so this is just a technical breakdown of how this works. As I mentioned before, our social care clinicians are documenting their encounters in the health system's EMR. They are also documenting their time in there. So what happens is the EMR calculates minutes in a flow sheet, and that report comes to the Area Agency on Aging on a monthly basis. From that, we generate an invoice to the health system. It's actually our social care clinicians that are entering the these codes that are on the slide here, and we embed in there links to the medical learning network where you can learn more about the requirements for billing these. But when we submit that invoice, then the health system actually submits the claim, is reimbursed by Medicare, and then pays the Area Agency on Aging. And you said you had a couple of
Yeah, actually, we can just go on to the next slide and I can comment on it there. So this is our payment evolution journey. We self-funded this with our healthcare partners in the beginning as we looked at a pilot and what this intervention would be. We got some grants to do the intervention, the interagency care team, transitioned it to these 2 contracts for Medicare fee-for-service with these 2 practices. And we're moving now toward a shared vision of moving to a value-based payment arrangement and some opportunity to scale this with more than the practices that we have in 2024. I will say our AAA is also a Medicare Part B provider, and there are many other codes that we bill directly. We also were just awarded some other opportunities in terms of the guide model and things where we can create a more dementia guided experience for our patients as well. So really looking at how do we start from just grant funded, develop a concept and move it forward through some fee-for-service contracts and move that into some both contracting with our healthcare partners and have them bill the Medicare codes, as well as be able to direct bill those codes that we're able to do so as well. So next slide, how do you get started? It really is about understanding your population needs and understanding your prospective partners' pain points, and really digging into what are the solutions that they're aiming for, what are the problems they're trying to solve, and how can you use the skill set that you bring to the table to do that. But really this work runs on relationships and really building those relationships, finding those physician champions with health systems and health payers. Use the proof of concept that we've done and that others have done. It's totally transferable to other communities. And then develop the data analytics strategy that can really develop. You have to show your ROI. But those would be some how to get started from my perspective. Theresa, do you want to add anything to that in our last minute?
No, I think that's great. There are some questions in the chat that I'd love to respond to as well. I don't know if we're ready to get to that point, but I see that are you using a specific assessment for health-related social needs? And we really felt that as we reviewed the existing instruments that are prevailing, we decided that composite, we really developed one that worked best and built on the experience, the 50 years of experience the Area Agency on Aging has in addressing health-related social needs and in screening and assessing for them in people's homes. So we've developed our own health-related social needs screening. And the social supports, I think maybe what the question is what social supports are specifically paying for this, for that.
Yeah, I can take that one. So it is so person specific. So as you saw, the health related social needs, it depends on what the need is of the patient. So as we identify the health related social need, really driving the service delivery based on that individual. So I can't speak to specific, it's all the social needs that you saw. We tapping our community-based organizations to meet those needs. So it is as varied as the participants. As you saw, one of the highest needs was mental health. So we have in-home behavioral health counseling. That was a huge one. Pest eradication. It really is across the board, and it is as unique to the patient. So if that's helpful.
Thank you so much, Christine and Theresa. I think that you're hearing and seeing some really wonderful comments in here. One thing I think that would be really helpful to speak to, and if you could go to the next slide, we'll put a slide up here for you all to feel free to come off of mute and engage with your case study presenters. But for those that are a singular CBO and are not a hub, where do you start? And also for our health provider partners on the table or on the call, what would you recommend that they do when they know that there are CBOs with staff in their hospitals, for example, to help facilitate transitions? What are those conversation points to begin moving the needle toward a more formal partnership? And it kind of gets to this question of what are you doing already? Supports coordination, social care. What guidance would you give in a non-hub environment to start making these things come together?
Yeah, one of the things that I would encourage is a slight shift of thinking because AAAs who are using Older Americans Act services, you already have contracts, you have a network of social supports to meet the needs of older adults. It doesn't come with enough funding to meet them. But think of yourself, you are that bridge to the community-based organizations. So I'd encourage you to kind of shift your thinking a little bit in that regard. But I would maybe a great place to start is connecting with your health partners around their community health needs assessment. Look at their latest community health needs assessment. Find your population there, find your solution, and begin to engage in the dialogue around that. What's their pain point? And then talk about what you bring to the table in that regard and how you can bring this network of community-based organizations. You might not be a formal hub yet, but you are the connectivity to the social support services system to meet the needs of older adults with complex care needs.
And is there any experience that you can lend from what you felt the health provider side was doing or what was helpful?
Yeah, I guess as I reflect on that, one of the things that was really important for us was to spend the time, like if I put my health plan and health system hat on, was really making sure that we were talking the same talk, using the same language. Often we were using the same words, and then we meant very different things. So when we talk about care coordination or care management, that looks very different in an ambulatory care practice or in a acute care setting versus what a community-based care management practice is. So really, I would encourage, whether it's the health payer, the health system, or the community-based organization, to make sure that as we're using language that we're aligned in what we really mean. And we used to call it for a while semantic stumbling, because we would say one thing, they would use the same words, and we thought we were saying the same things, and we meant very different things. So investing the time in understanding your partner's perspective, whether you're the health plan, the health pay, or the health system, or the CBO, and aligned around those common objectives, I think that's a remarkable place to start.
And I know that this is our case study questions, but Nikki, I know you're off camera and you're on camera, and you also bring a wealth of knowledge. Feel free to come in and add perspective if you have anything else you'd like to share from your own experience.
Yeah, as far as working with healthcare, I'm just want to make sure I got the question right. Healthcare partners? Are you saying from the healthcare partner perspective?
Yeah.
There's already great work happening. I mean, the CBOs are the social care experts.
Mm.
And so don't be afraid to reach out to them to find out what they do and how you could best support them. They might need some upfront capacity funds to be able to do this work with you, but they're very flexible. If you just look at COVID, all the CBOs pivoted on a dime to make sure everybody got the services they need. So they've already proven that they can do the work and meet the needs. So reach out and be available, because a lot of times half the battle is, who do I talk to with health plan? I don't know who to reach out to. I can't get a contact.
Yeah. I'd layer on. Thank you for that, Nikki. As I encourage our health system partners to build on the expertise that already exists rather than try to build it internally. You've got those social care clinicians in the community. And as we talk in our community with our health systems, we talk about this being a social care specialty referral, just like they would refer to any other specialty: neurology, cardiology, social care referral. That is the referral to this network. You've got a specialty network in your community.
And would you clarify for some folks that might not be familiar with the term social care clinician, what type of staff person would fit that title?
Sure. So for us, it's both. It's multifaceted. So it's nurses, it's social workers, it could be community health workers. It depends on what is called for in terms of what's allowed under individual codes. So many times it is not a licensed clinician. Many times it is a nurse or a social worker, but many times it's a certified community health worker, a long-term supports and services navigator. It's a housing coordinator. These are the experts in the field in social care and addressing health-related social needs.
Excellent. I think that opens up a whole other perspective for folks that are in the CBO world and are wondering who of their staff might fit that.
Mhm.
Which is another follow on, what kind of licenses, certifications might be needed to build the codes like 0591 or social care clinicians? I think you kind of just talked on that, but anything that you want to elaborate on?
The only thing I would say is the Medicare Learning Network is one of my best friends. When you look at what code and what do you need, what are the clinical requirements, what are the documentation needs, et cetera. So there's a wealth of information. So as you dive into each of the codes, the Medicare Learning Network is the source of truth there.
Great.
I would just add for the 0591 codes that we use for the health coaching codes, there doesn't have to be a certification at the CBO. That the hub is required to make sure that whatever the direct staff that's providing that ensures that the coaches have specific training on motivational interviewing, person-centered care planning, trauma-informed care, resources, benefits. So it doesn't have, we don't have to add that burden to the CBOs to get another license or a certification as long as they get the training, which is nice.
Great. Thank you, Nikki. And then there's a question about reduction in length of stay. What specific interventions or interactions are taking place bedside to reduce that length of stay?
Sure. So our social care clinicians are able to intervene either telephonically or directly in the hospital with patients. They talk about what are the barriers to returning home, and whatever those barriers are, they follow the patient where they're at. So it could be connection to home delivered meals. It could be connection to any number of services that the community-based organizations in our network provide. It also could just be health coaching and helping navigate, maybe coordinating care with the family to make sure that there's someone there when mom comes home to take care of her and meet her needs. It just is a full range of services, but the notion is that there's somebody there to help navigate, to assess what that unique need of that patient is and help them navigate this complex system of coordinated services and make it seamless for them. That stuff, those are things that the hospital staff don't always have time to be able to work out with the person individually. And it's also things where, because we've been working with the patient, we have a relationship, we have that trust, and so we can break through really immediately to what that need is that is preventing them from being able to go home sooner.
Right. One thing that I know our participants and some folks that are on the call today have shared in our peer working sessions, you talked about the fact that you use Epic and you actually engage with Epic. And one of the challenges that folks have experienced is that it's a read only for many people. What is it that you do or did that allowed you to move beyond read only and really only kind of a passive interaction with the health record to what you're doing today?
Appreciate that. Yes, at our beginning of our partnership, before we were under contract, we had Epic Care Link, so just that level of access where you could read only but not really chart. Once we executed contracts, so once we were under contract with these two physician practices, our staff are treated just like any other locum staff or any other contract extender staff that the health system would have. So they are logging into their instance of Epic just like they were employed by the health system. So that gives them full access, and that's really allowed for that one care plan that Theresa talked about, not just At first, we were like sending PDFs, and then the medical team would upload that to the media tab, and physicians rarely had time to take a look at that. So that has been a game changer for us. And as we look to scale this to a broad system of broader population and more physician practices, cognizant of the fact that we can't have our teams logging into 10 different instances of Epic. We really have to be able to scale this in a way. So we are also working with the Health Information Exchange Network here in Michigan on an interoperability pilot so that we can use our own EMR, which is Athena at present. That's the EMR that we have, so that we can document and then share that electronically through the Health Information Exchange Network. But that was the key for us, is by having a contract to do this care management work, chronic care management and other work that went up through their compliance chain, the health system compliance chain, and got the stamp of approval that it would be just like any other contract staff that they have.
Excellent. And we do have a question in here about whether any of you have a process written on how you've created where you are with your successes. And written steps supports how maybe it could be helpful to share beyond. I do know in the resources and what we will post, you have your Hartford Awards and overviews of a lot of that, the Aging and Disability Business Institute, which we'll show on our resource slide here. We've included some of that, but would any of you like to speak to Kevin's question?
I really appreciate your question, Kevin. And I will say tentatively, we do have, we had a contract staff person put together a bit of a playbook on how we got from where we are to where, from where we started to where we are. It is not ready for prime time, if I could say it that way. And I think Theresa would concur, but I do recognize the value of that. And perhaps we could spend some time polishing that up a bit. That might be of benefit.
As far as, I mean, I guess we do have processes written. I'm wondering, I would want more information on what you're looking for. Are you saying just kind of like our timeline and how we got to where we are, or are you trying to dive more into the different processes? So feel free to reach out, and I mean, we have some stuff all mapped out, and other things we're in the process of really getting like more of a, process and procedure manual. But I like what you're talking about, Christine, kind of like a broad overview. Thank you.
I have a question that I think feeds into sort of where a lot of the organizations that we've been, supporting through this series are at. Christine and Nikki and Theresa, for all three of you, in your role as a biller and having these arrangements with CBOs and with a network, can you share, if you could just put on your Part B provider hat and think from a perspective of when a CBO is supporting the work that's being done and providing services, what are those key elements that you expect from a CBO in order to make that, as imagining like a new CBO partner coming on to provide that service? What are you expecting from those CBOs to be able to not just provide the service, but provide all the documentation and the necessary supports you need to be an accurate biller for those services? What are those essential elements that you're looking for? And obviously following up with to make sure that they follow through on.
You want to go first, Nikki?
Sure. So every time we contract with a new delivery partner, they go through first our compliance training. They have to be all HIPAA, fraud, waste, and abuse, have all their insurance docs. Then we do training with their direct service providers, and we always have them assign a program supervisor at their agency, because we're not their supervisor, we're their partner, but we always want to make sure they have a supervisor there that can be overseeing their direct support. And then we're their partner throughout the whole project. So we're doing quality assurance, we're checking their charts before we bill. So if anybody's missing documentation, we're reaching out. And really that's another value of having that kind of hub agency, to where, you know, you're always having someone making sure, and we're there too if they get stuck with a client or there's an incident. A lot of times, maybe there's an incident where the client isn't happy or the client fell or something has to be escalated, and we take that role. We do all the data sharing back to the plans. Maybe they're eligible for more services and the coach doesn't know how to get them. We will help them with all that. So once we train them, we're there with them the whole time. We're not just kind of sending a referral and saying, okay, let us know. We also train them on our documentation portal. It's really hands-on.
Yeah, I'd echo that, and for the AAAs and then in the network, you know, this really builds on the work that we already have been doing for so long, in terms of developing a provider network to do this work, all of those things around all the compliance issues and the quality, but also coming alongside them, walking alongside them to make sure they have this. Some don't need much support, and they really have great processes and already aligned. There are some that we have to do a lot of technology hand-holding on. You know, we have some new requirements here in Michigan around electronic visit verification, which was really a different contract. But, you know, really, our compliance officer sat in an office of one of our community-based organizations for an entire afternoon, walking through and helping them get connected to the technology that they needed to be able to do this work. So it is a partnership. And it isn't, and I think that's one of if we could go back to the build versus buy from a health system or health payer perspective, this is work the AAA network already does. And so, and it isn't just send out that referral and then tell me if they got served or not. It's so much more than that.